Hello and welcome. My name is Alice, and I'll be in the background answering any Zoom technical questions. We encourage you to submit written questions at any time using the Q&A box, which is located on the Zoom panel at the bottom of your screen. Finally, during today's event, live closed captioning will be available in English and Spanish. You can find the link in the chat field. With that, I'd like to introduce Tyler Sadwith, the California State Medicaid Director at DHCS.
Terrific. Thank you, Alice, and good afternoon, everybody. We're here to provide an overview of the Birthing Care Pathway, which the Department of Healthcare Services began developing in 2023, and we published a report on the Birthing Care Pathway last month. Really looking forward to sharing information about sort of our journey developing this resource and some of the information included in it. As you'll hear today from our team, the Birthing Care Pathway is a comprehensive policy and care model roadmap that covers the journey of all pregnant and postpartum Medi-Cal members all the way from conception through 12 months postpartum. Our goals in launching the Birthing Care Pathway are to reduce maternal mortality and morbidity for all Medi-Cal members and specifically address the significant racial and ethnic disparities in maternal health outcomes that we unfortunately see among Black, American Indian, and Alaska Native and Pacific Islander individuals. Taking a step back, like the rest of the nation, California is facing a maternal health crisis. While California's pregnancy-related mortality ratio is lower than the national ratio, it has been rising in recent years, and the majority of these deaths are preventable. California's severe maternal morbidity rate has also been rising, and unfortunately, that is higher than the national rate. We know 1 in every 8 births in this country takes place in California. We know 40% of those births are covered by Medi-Cal. This department is uniquely positioned to drive significant improvements in maternal health and birth equity policies and outcomes. So to develop the Birthing Care Pathway over the course of the past year and a half, the department conducted a landscape assessment of California's existing maternal health policies and initiatives, reviewed national best practices and evidence-based programs, interviewed more than 24 state leaders, maternity care providers, community-based organization leaders, Medi-Cal managed care plan representatives, and birth equity advocates. We launched 3 work groups focused on clinical care, social drivers of health, and the postpartum period. And for the first time, recruited a cohort of pregnant and postpartum Medi-Cal members to share their lived experience, their feedback, and their recommendations through focus groups, interviews, and journaling over the course of several months, which is foundational to ground and inform our policy work. In addition to investments made by the department in this area, we've been fortunate to have support from the California Healthcare Foundation and the David and Lucille Packard Foundation as well. So on behalf of the department, just want to say thank you to all of the feedback we've received from all of you, from experts, stakeholders, from Medi-Cal members. Thanks to you, we were able to publish the Birthing Care Pathway report last month. The report includes a series of policy solutions and strategic opportunities for further exploration that are designed to address the physical, behavioral, and health-related social needs of pregnant and postpartum Medi-Cal members. These include highlights of work that we are undertaking now to improve access to providers, strengthen clinical care and care coordination across the continuum, provide whole person care, and modernize how Medi-Cal pays for maternity care. During the discussion today, you'll hear an overview of literally the dozens of policies the department is implementing as part of the Birthing Care Pathway and our progress to date in these efforts. We also plan to share strategic opportunities for further exploration. These strategic opportunities are really important to continue considering. They're subject to additional assessment and planning and contingent on a few external factors, such as legislative authority or additional state budget authority. We recognize many of you joining us today have been offering recommendations to advance equitable maternal health over the past several years. And to this, I want to say thank you. We are so appreciative of you for sharing your time, your expertise, and your experience with us. All of your insights were tremendously helpful in designing the birthing care pathway. We look forward to continuing to engage with you. So with that, it's my pleasure to hand it over to Dr. Pallav Babaria, who serves as the Chief Quality and Medical Officer, as well as the Deputy Director of Quality and Population Health Management here at the Department of Healthcare Services. Thank you for being with us today. Pallav?
Thank you so much, Tyler, for kicking us off and laying the groundwork for the next 90 minutes that we are going to spend together. Before we dig into our agenda for today, I will say, I think we all recognize, let's not beat around the bush, that these are some challenging times that we are all experiencing and living in. And what I'm really excited about the next 90 minutes is the policy roadmap that we're going to walk through, as well as all of the initiatives that they are being done. They truly represent the collaborative, resilient spirit of all Californians, and most importantly, everyone on this call and others who are serving Medi-Cal members every day and really striving to improve quality and equity in our program. Hopefully what it shows is that there's a lot we can do when we all come together and are rowing in the same direction, and really being able to rise above our own silos in this process and connect and partner not just within the Medi-Cal program, but across multiple state departments has really led us to the moment that we are at today. So thank you all for joining. As many of you know, for all of our quality and health equity work, we really want to ground the why of the work in the lived experiences of our Medi-Cal members. So really excited to kick off today's webinar with two member stories. The first one comes to us from Pamela, who is a Medi-Cal member with Partnership Health Plan from Solano County. When she was pregnant in 2024, she benefited from a number of different services through her health plan and local community. These services included Growing Together program, which is open to all pregnant and postpartum partnership members, as well as families with children up to age 5. Their program seeks to connect with pregnant and postpartum members and really support them in getting appropriate and timely prenatal care, empowering postpartum members to attend their well care and well child visits, and really building strong patient and provider relationships throughout the pregnancy and postpartum period. So I'm going to turn it over to the video so we can hear directly from Pamela about her experience.
Hello, my name is Pamela, and I would like to briefly talk about my personal experience with my pregnancy journey with Partnership Health Plan of California. So they offer doula services, which can be online or in person, and also getting your breast pumped for breastfeeding moms, and many more other supportive services through the Growing Together program, which essentially is personalized according to your personal needs. In my personal experience as a pregnant mom, my anxiety and mental health was taken care of through gradually consistent phone calls just to make sure that baby and I are okay. Partnership Health Plan is truly more than just a health plan, as they will go the extra mile to walk through the journey with you, not just during your pregnancy, but postpartum too. So I would highly recommend anybody, especially new moms, to make use of every resources that they offer.
Next, we're going to turn to Anita Chacon-Terry, who is a manager of care management and transitional care services at HealthNet, which is one of our Medi-Cal managed care plans operating in multiple counties throughout the state, to share another story from a Medi-Cal member that she is working with. Anita, I will turn it over to you.
Thank you very much. I would like to share the story of our member, a 32-year-old female that our transitional care services team connected with upon her hospitalization. This member had a stillbirth at 38 weeks. She had been receiving prenatal care from her Medi-Cal doctors, including OBGYN care. Once she had gone to the hospital, our transitional care services team reached out to offer our services and support. Our care manager did an initial assessment and offered behavioral health care resources due to the member's struggle with grief. She also offered doula services to her. The member had voiced that she was unsure if she was ready to start therapy and declined the doula services. The member voiced that she was planning on, she had family support and she was planning to discuss her emotions with her provider at her follow-up appointment. However, when our care manager did her next outreach to the member to complete our postpartum assessment, the member disclosed that she sometimes had thoughts of harming herself. The care manager then decided to warm transfer the call with the member's permission to our crisis line to have the member further assessed for immediate behavioral health needs and support. The member is now linked to behavioral health services. She was provided resources for support groups, and this included online support from our online support chat, as well as family bereavement support. The member has completed her goals in our postpartum transitional care program and has been referred to our behavioral health care management program to provide more long-term care management support and ensure the member is linked to behavioral health resources and providers. Thank you for allowing me to share our member's story.
Anita, thank you so much for joining us today and sharing that story. For those of you who may be less familiar, transitional care services is one of our newer policy requirements that went live as a part of our CalAIM population health management program in January of 2024, and requires specifically for high-risk members who are being discharged from a hospital or another setting for them to have a dedicated care manager. And we made an explicit policy decision to include all pregnant and postpartum individuals being discharged in that policy, exactly to help support members like the one that Anita talked about. So thank you both. Hopefully that gives a little bit of context and real lived experience to the why of why we're here and doing this work. We can go to the next slide. We can go one more. So we're going to spend the first portion of our webinar today really talking about what is DHCS's vision for the maternity care in Medi-Cal, and what's the process that we took to actually develop the birthing care pathway. As many of you know, as we've been doing our policy development, the process we take and who we engage and how we listen to them is a key part of our strategy to address health disparities and achieve health equity in our state. And so even though it may not be right away getting into the nitty-gritty policy details, we actually think this is foundational to all of the work that we are doing. So those of you who haven't read it yet, you can link to our website and the full Birthing Care Pathway report. All 130-something glorious pages of it are available online and have a lot more detail. But we hope that after this multi-year collaborative journey that is really going to require partnerships across state departments, with local counties and governments, with all of the providers, social service sector providers, and members across the state, that we can really make sure that Medi-Cal members have access to all of the maternity care providers and services that they are entitled to under the Medi-Cal program, regardless of where they live. We know that access is not even across all parts of our state today. We also want to make sure that members can really get risk-appropriate care and are empowered to choose what type of provider and birthing location that aligns with their needs and their preferences. And we also want all members to feel respected and heard throughout their pregnancy and postpartum journeys. We also want members to be educated and knowledgeable about the services that are available to them, and that they can get support navigating these services, especially in that really crucial postpartum period where they are juggling their own care needs with the needs of their newborn child. We also heard loud and clear and want to support access, expansion and access for all behavioral health services and social supports for members, their newborns, and the larger family in which they reside. And then we also heard a lot of opportunity to really improve care by streamlining data collection and supporting data exchange so that there is enhanced care coordination and visibility locally. You can go to the next slide. So as mentioned, on the website, there is an actual document, which is the Comprehensive Policy and Care Model Roadmap. As you read through it, and as you'll hear in today's webinar, Many of these pieces are ones where DHCS is taking lead, but as we heard from all of our stakeholders and our members, to truly achieve the vision we just laid out for maternity care and postpartum care in Medi-Cal, it's going to require much partnership and collaboration and support far beyond DHCS. It includes policy solutions that are whole person in alignment with our CalAIM objectives, that we're not just talking about clinical maternity care, we're also talking about behavioral and health-related social needs. And our goal is explicitly to reduce maternal morbidity and mortality and close the significant racial and ethnic disparities that persist to this date in our state. We can go to the next slide. So the report, as mentioned, has a lot of details. We'll be doing a high-level overview today, but it walks through our entire process and does a deep dive into all of the feedback that we heard from members and stakeholders, and then also provides sort of more detailed information on the policies that we are both implementing as well as proposing for future exploration. And I would be remiss if at this point I didn't pause to thank our funders. The entirety of this work, and especially the significant member engagement work that we did, including member stipends, were generously supported by both the California Healthcare Foundation and the David and Lucille Packard Foundation, and we're really grateful for their support that enabled us to be here today. You can go to the next slide. So I'm going to be going into these in a little bit more detail, but we really took a multi-pronged approach. I think as Tyler opened up, we have been hearing about challenges and also opportunities for improvement in our maternity policy from a variety of sources for a while now. And we knew as we started to peel back the layers of the onion that maternity care is one of the oldest parts of the Medi-Cal program, which is great because it means these services and benefits have been around for a long time. But it also means that there's a lot of layers and things have been added over the years. And there's a lot of parts of our policy that hadn't been updated in a while. So to really make sure we were taking a comprehensive, transformative approach, we did a landscape assessment to review all of California's existing policies, as well as look at evidence-based practices and national best practices. We engage Medi-Cal members directly because at the end of the day, it doesn't matter what we have in our policy if that isn't translating into the lived experience and services that are touching our members on the ground every single day. We also interviewed state leaders, providers, community-based organizations, associations, health plans, and advocates to get a broad base of perspectives on where things are going well and where there's opportunity for improvement. And then we had a series of longitudinal work groups, one focused on clinical care, one on social drivers of health, and a postpartum work group, which I'll talk about more, to really delve into the policy details and help suggest solutions and really guide the development of the report. We can go to the next slide. So I do think one of the most novel pieces of this work compared to other policy initiatives that DHCS has undertaken is how we engage Medi-Cal members. As many of you know, as a part of our comprehensive quality strategy, as well as DHCS's strategic plan, we are very intentionally trying to engage members and have them inform our policy decisions because at the end of the day, our program exists in service of our Medi-Cal members. So for this project, we engaged 30 members who are either currently pregnant or up to 24 months postpartum and invited them to share their lived experience with us. We purposefully selected individuals so that we could get a broad representation across the state. We know that the experiences of members in regards to maternity care looks very different if you're living in Los Angeles compared to Humboldt County. We also tried to select for people who are at different phases of their pregnancy journey, different age ranges, different races, ethnicities, and different other lived experiences to really have a diverse group. We then did deep dive interviews with 6 of the members. We had 6 members who did longitudinal journaling throughout their pregnancy period because we know that your experiences in the prenatal period, for example, may look different in first compared to third trimester or compared to the postpartum period. And then we also had a member voice work group with 18 members that had 3 work group meetings, as well as a debrief meeting. They got a preview of this report before it went public to really learn from the group as a whole and digest a lot of the findings. I will also note that we asked for funding from our generous funders to engage 30 members. We had the invitations to join this member work group sent out through many of the stakeholders and providers and CBOs and other groups that we were working with. And we got 400 applications, which we were blown away by. We thought it was going to be hard to find 30 members, and definitely did not expect that 400 Medi-Cal members would really want to participate in this project. And I think it's really a testament to how much people want to make our program better and provide that feedback. We can go to the next slide. I'm going to walk through these member findings a little bit in detail because I do think these are the heart and soul of our Birthing Care Pathway report. At the end of the day, if we don't address these 6 findings, our project and our roadmap will not have been a success. So the first 3 themes that you see listed on this slide, these were the top themes from our member voice work groups and our member voice findings that they really said, this is what we want out of our Medi-Cal maternity experience. First and foremost, the members said that feeling respected and heard by their healthcare providers is critical to their experience. Some members had great examples for this, but many others had specific examples where they felt like their choices and preferences, whether it came to the birth or breastfeeding, were dismissed and belittled and not taken seriously, and it really changed their entire experience. We also heard from some members, unfortunately, that they had multiple experiences with discrimination in their healthcare encounters during all 3 perinatal phases. Some members felt that they had better care or felt more heard when they received racially concordant care. And then we heard pretty consistently, loud and clear, that often key moments for trust building with members were often missed. Specific examples of this were behavioral health screenings that were done, and then the results were never communicated to the members. So they had no idea if they screened positive or negative or needed a follow-up. There were times where a trauma-informed approach to care was not taken, and a member who was experiencing intimate partner violence was screened for IPV in front of her abuser who was in the room with her and couldn't answer the question honestly. Many individuals had bumps and issues when they were transitioning from the labor and delivery and hospital setting to home, and often key follow-up appointments or access to DME and breast pumps was not completed. One example we heard from a member was her infant had to stay in the NICU for a few extra days because of jaundice, and she was told your baby needs care within 24 to 48 hours after discharge, but she wasn't connected to a pediatrician and wasn't given any instructions on how to access that care and was really worried about the safety and health of her newborn. We can go to the next slide. The 3 themes that you'll see that I'm going to walk through also came up in our member voice work group and were also really consistent from a lot of the feedback that we heard from our other work groups, which we'll cover in a few minutes. So it was often felt that the onus to navigate all the different aspects of perinatal care was often put on the member. So both in the prenatal period, but also postpartum, when the member was often caring for an infant, trying to get medical care for themselves, for their newborn infant, also trying to get key social services, whether that was CalFresh or WIC or lactation support or behavioral health services. Everything was fragmented. And at some points, our members just gave up, that it was too much trying to go to 15 different appointments, and they forwent critical services because it was just too hard to coordinate and access them. We also heard loud and clear and consistently that finding behavioral health providers, both for mental health as well as substance use disorder, was very difficult, and that often members face long wait times to even get an appointment with a behavioral health provider. And then when they did finally have an appointment, sometimes those behavioral health providers told them they didn't feel comfortable caring for pregnant or postpartum individuals, and they had to start the process all over. And then throughout all of our work groups and member findings, many of the members had no idea all of the benefits that Medi-Cal covers. So in one of the work groups, a member was talking about how positive her experience with a doula was, and everyone else in the group had no idea that Medi-Cal even covered doulas. Similarly, for key benefits like enhanced care management or WIC or CalFresh or transportation services, there was a lot of gaps in knowledge of what they were entitled to. We can go to the next slide. So the other piece here is that we did key informant interviews, as mentioned, that we really wanted to interview all of the different people who touch maternity populations across the state. So we had lots of interviews with provider associations. I'm not going to read all of them out here, as well as individual providers who represent the different provider types listed here. We also connected with county leaders, especially from public health, who provide a lot of local wraparound services for pregnant and postpartum populations, as well as CBOs who are participating in CalAIM and otherwise who really focus on providing specific services for specific subpopulations. We can go to the next slide. And then these are the 3 work groups that I mentioned. So in addition to the member stakeholder engagement, all of the landscape scan and the interviews, we had 3 groups that met longitudinally. The clinical care and social drivers of health groups met over the course of 2 years multiple times, and the postpartum subwork group met for about 12 to 18 months. So the purpose of the clinical care work group was really to focus on the clinical needs of our members. What is the actual medical behavioral health care that our member needs, both through the prenatal and the postpartum period, all the way through 12 months postpartum. And we do recognize this is team-based care, so really included, physicians, midwives, lactation consultants, doulas, tribal health providers, freestanding birth centers, behavioral health, and FQHC providers, as well as plans and public health. The social drivers of health work group was really laser focused on what are all of those other health related social needs that we need to coordinate and connect to provide that whole person care to the members. This group included community health workers, doulas, violence prevention organization representatives, social service and public health groups, housing providers, home visiting providers, and providers with Black birthing experience. I will also acknowledge this distinction between clinical and social care is somewhat artificial. So we had a lot of overlap between these 2 groups and did synthesize their findings, but we really wanted to create a safe space where people could do a deep dive into their areas of expertise. And then the postpartum subgroup also had members from both of these groups as in addition to others, and really was focused on that 1-year postpartum period. As many of you know, Medi-Cal expanded Medi-Cal coverage for individuals who qualify on basis of pregnancy from 60 days to 12 months, similar to many other states under the last administration. And yet the clinical pathway for what are the services someone truly needs for that 12 months period, what are their challenges and where can we help them, was really unknown. So this postpartum sub-work group was really focused on building out that clinical pathway. We can go to the next slide. So this is a summary of the Birthing Care Pathway partner engagement findings. It is probably not news to many of you on this call who work in the space daily, but access to maternity hospitals, especially in rural communities, is rapidly diminishing. And there are many areas where we do not have enough maternity providers or any maternity providers to care for their local populations. We also heard specifically about some of the challenges for midwives and lactation consultants and the barriers that they can face in Medi-Cal provider enrollment as well as reimbursement. And if they can't get enrolled in our program and they can't get paid for providing services, this in turn really limits Medi-Cal member access to these services. We also heard about long appointment wait times and not having enough behavioral health providers who really are comfortable treating pregnant and postpartum individuals, which really limits access for this population, sometimes with really catastrophic consequences. And then we also heard from these groups that there's a lot of deep silos, both in terms of data sharing, communication, care coordination, and collaboration, and that really breaking down these silos between different types of providers is needed to deliver coordinated care. Specific examples we heard is someone could be engaging with WIC and have an entire WIC care plan on a regular basis, and then sometimes they show up to labor and delivery and no one knows what's in that care plan and doesn't have visibility into all of that great work that's been done or what risk factors an individual has, or vice versa, that there could have been a tremendous amount that happens during the hospitalization with huge impact to the member and the newborn. And then sometimes in the postpartum setting, they show up to an appointment and no one knows about that hospital labor and delivery course. And then we also heard about the promise and opportunity of using group care models like centering pregnancy to really provide whole person care and build community, especially hearing from some of our members that social isolation and not having a strong support network was a major issue. We can go to the next slide. We also heard consistently that while folks really value the Comprehensive Perinatal Services Program, CPSP. I think we all know CPSP was founded in the 1980s and has not necessarily been updated much since then. And so there's a lot of opportunity to modernize CPSP to really align with how clinical services and social services are provided today that could really help uptake and use. We also heard that pregnant members are not always being consistently connected to providers and facilities that meet their risk level. So obviously, if a member is high risk, whether that is because of medical conditions or behavioral health conditions, really needing a facility that can accommodate that level of risk, and that doesn't always happen. We also are clearly in a housing crisis in our state, and our pregnant and postpartum members are no more immune to that than other populations. And so consistently, lack of housing and homelessness were cited as major barriers and issues that really needed to be solved to support pregnant and postpartum members. And then also thinking about, we heard this from our work groups, that how can we educate Medi-Cal members from all of the resources that they're entitled to, and then really take on that navigation burden, which right now that onus is entirely on the member. We can go to the next slide. As I mentioned multiple times so far, this is really a group effort. These are all the organizations that we've been connecting with and working with, and I'm sure we did not get all of their logos on here, but if you look at the report, there's much more detailed information about who participated in all of those work groups that I mentioned, and who's been a part of the review process for the Birthing Care Pathway. We can go to the next slide. So I know that was a lot of information about the process and how we got here. I know everyone is excited to move on to the policy pieces, but I'm going to pause there and ask our team who's moderating, what questions have folks sent in that we want to tackle before we move on? And if you haven't sent in a question, please use the chat or Q&A feature to do so.
So Paula, we had a few questions come in about the member recruitment process for Medi-Cal member engagement. How did DHCS recruit pregnant and postpartum Medi-Cal members to participate in the Birthing Care Pathway member engagement activities? And what were the demographics of those members who were selected and participated?
Great question. So as mentioned, we had these clinical and social drivers of health work groups. The rosters are available online. And we know that, the individuals and organizations serving on those work groups work with pregnant and postpartum Medi-Cal members every day. So we had our recruitment flyer with instructions of how to apply if you were interested and what the time commitment and stipend would look like. And then it was really our partners who distributed that call or request for participation to their networks and their clients and their patients that they would work with. And again, I think we were just blown away by the response that so many people wanted to, devote their time to supporting this cause. And then we did, in hindsight, we should have asked for more funding to be able to accommodate more than 30 members. So that is a lesson learned for next time, is that there is a lot of interest. And had we had more funding, which was the constraint here, we could have accommodated more than just 30 of those applicants. And so given that we were limited to the 30, we really did try to make sure that we were having a good mix of diversity on the group based off of geography, lived experience, sexual orientation, social drivers of health, behavioral health or justice involvement, as well as race and ethnicity. And so ultimately the group that was chosen was as diverse as we could make it across all of those demographic lines.
Thanks, Paula. I think in the interest of getting to the policy roadmap portion, we're going to move on, but we will have other opportunities for questions, so keep them coming in through the Q&A.
Okay, great. Let's keep going. So now we're going to get to the meat of what I know everyone is here for. What are we actually doing with all of those lessons learned and feedback and thoughts? We can go to the next slide. So the report, if and when you get a chance to read it, is split up into two portions. One is, what are policies that DHCS has committed to implementing or is in the process of implementing? For the most part, these are policies that we didn't need additional resources for, we didn't need additional authority or state statute for, and that were in our control to start moving on right away. And so you'll see today, we started this listening tour for the Birthing Care Pathway project, over 2 years ago. And so some of these policies, we didn't want to sit on it and wait for the report to come out. If it made sense and it was recommended by our stakeholders that we could do it, we started moving on implementation. So that's why some of these are already completed. So there's 42 policies, 10 are done. 27 are sort of in progress, and 5 we have yet to start, but we will be getting to them as soon as possible. We'll get into in the next section what are some of the strategic opportunities for further exploration. And those are policies that we heard loud and clear from listening to all of you and our members and other state partners, that they're a good idea, but they're going to be a heavier lift and or require some sort of investment or authority or resources that we don't have today. We can go to the next slide. So the 42 policies are split up in these 8 focus areas. Not going to read them all out loud because we're going to go through them in detail, but this is how the report is organized as well. We can go to the next slide. So the first bucket is really provider access and managed care plan oversight and monitoring. I think everyone is tracking this, but as of 2024, we estimate that 99% of all Medi-Cal members are now enrolled in our managed care plan. Because of how pregnant individuals are enrolled in our program, that percentage is slightly lower for pregnant individuals, but it is still true that most of our pregnant individuals and postpartum individuals are enrolled in a Medi-Cal managed care plan. So making sure that we are providing access and doing the appropriate oversight and monitoring of our plans is a key need to improving maternity care. So some of the problem statements that we were trying to solve is that in current state, we heard loud and clear, especially from our members, that we have limited diversity in the workforce for who provides maternity care. And our members really want options in terms of who their providers are, both what types of providers, as well as the sort of cultural humility and linguistic concordance of those providers. We also heard about just delays getting basic things like breast pumps and having a lot of issues with the transition after hospital-based birth to home. So the specific policy solutions that we are working on, one is that DHCS has an existing loan repayment program for physicians called Cal Health Cares, and we are working on really leveraging that program specifically to improve the pipeline and access to a diverse OBGYN and family medicine workforce, especially in those parts of our state where we know that there is no maternity provider or there's very few limited maternity providers. We're also working on streamlining the requirements for approval and how members get high quality breast pumps. This was another part of our policy that I think had not been updated in some time. There have been a lot of advancements in breast pump technology and quality. And then we're also working on additional guidance and policy revisions for our managed care plans when it comes to transferring to different care settings and levels of care for pregnant and postpartum members. We can go to the next slide. The other piece, again, from all of the listening that we did, is that we really need better member-facing communications that tell them what they can access and how, and make that process really easy. So we are currently in the process of developing those member-facing materials and communication tools. One of them was launched as a part of our Birthing Care Pathway report launch and is available on our website. So if you work with Medi-Cal members, please go access that. We have translated it into threshold languages and start using it if you aren't already. We're also, one of the things we were able to complete is a standing recommendation for doula services. In current state, to get a doula, there does need to be a standing order. And we were able to do that at the state level, at the DHCS level, such that members don't have to find someone to order or recommend the doula. And then we're working on a doula directory, which is done for use by Medi-Cal members, providers, and MCPs to really make sure that, to the extent possible, all the doulas who are interested and willing in serving Medi-Cal members can participate in our program. And then we also have been working with our doula implementation stakeholder work group, which is still ongoing, to really work through a lot of the challenges and issues around our doula benefit to make sure that we can support our doulas and make sure that all members who want a doula have access to one. And we did hear consistently in our member work groups that they really valued the doula experiences that they had, and it was a really incredible part of their birthing experience. We can go to the next slide. These are the member fact sheets that I alluded to. There's two, one around sort of the medical care team for the pregnancy, as well as other services that are wraparound services. They have been translated, so please use them liberally, share them with anyone who you think could benefit. We can go to the next slide. The other two policies, which are still in progress, one is we are working to survey our members to figure out what's working. you heard two amazing success stories from our plans that kicked off this webinar. There are other solutions that our plans have found, and how can we support in scaling those best practices across the state, as well as reduce administrative burden for our providers. We also recognize, and this is a little bit wonky, but as mentioned, our maternity policy, because it's been around for multiple decades, is layered on top of each other and exists in probably, a dozen or more different places. And so we are working to both modernize, update, and consolidate all of that into one place. Because sometimes people don't even know what the policies are, because some date back 30 years, some date back 10 years, and they've gotten buried. So we're really working on a one-stop shop for all maternity care policies for our managed care plans that will make it much easier to know what are our members entitled to, what are the requirements, and then how are we going to get those services to all of our members. We can go to the next slide. The other pieces, and you'll see the problem statements that we were trying to solve, are really around midwifery care, as well as subcontracting arrangements. So we heard loud and clear from our members that where possible, obviously medical risk may require a higher level of care, but they want a choice of providers. And many of our members were unaware that they could access midwifery services or lactation services, or there were specific barriers into getting those services. So one of the things we've been working on with our midwife partners and midwifery associations is really streamlining Medi-Cal provider enrollment and reimbursement requirements, taking away unnecessary barriers that were sort of going above and beyond what state licensing requirements were, and making it difficult for midwives to participate. So a lot of that has been improved. We're also working to clarify network adequacy requirements for our managed care plans to sort of raise the bar of how many midwives, certified nurse midwives, licensed midwives, and freestanding birth centers an MCP has to contract with. And then we also are looking at sort of what network agreements and delegated arrangements look like. We know in some cases, maternity care was delegated to either another plan or an IPA or some group. And then if that group didn't provide lactation services, our members were having a hard time, for example, getting those services that weren't included in that delegation. You can go to the next slide. The next bucket is really behavioral health and trauma-informed care. So we know that there's a lot of needs, both among children and youth when it comes to behavioral health services, but also opportunities through dyadic services and other CYBHI investments to really treat the whole family and treat postpartum individuals along with their children in the pediatric setting. And so we've been working on raising awareness through our CYBHI initiative. And then in current state, we are also going through all of our Medi-Cal managed care plan contracts. Our managed care plans provide non-specialty mental health services, as well as our county behavioral health contracts, which provide substance use disorder and specialty mental health services, to look at, are we specific enough that the providers in both of these contracts must be qualified to take care of pregnant and postpartum individuals, and strengthening contract requirements where needed so we can make sure everyone has access to a provider who's qualified to take care of them, and that we don't have those scenarios where a member is waiting weeks or months for an appointment only to find out that that provider won't treat the individual because they are pregnant or postpartum. We can go to the next slide. The other pieces that we heard about, especially when it comes to substance use disorder, there was some provider confusion around how long a postpartum member could stay in a residential treatment setting for substance use disorder. And so we have already reinforced our existing policy that there is no maximum stay for members receiving residential SUD treatment, as well as updated and shared the substance use disorder perinatal practice guidelines to all of our SUD treatment providers. The other big bucket, as you heard me share from those member experiences, is that it is really critical for all of our members, but especially those who are pregnant and postpartum, that they receive care in a trauma-informed manner. We know that for individuals experiencing intimate partner violence, that risk is significantly elevated during the pregnancy and postpartum period, and really making sure that all of our providers are trained in this, and that we are very actively, appropriately screening for adverse childhood experiences, intimate partner violence, community violence, and racism, and connecting people to resources is really critical. So we are working on those policy updates right now. We can go to the next slide. The next bucket is really risk stratification and assessment. So I think many of you are tracking is that as a part of our population health management program, we require all of our managed care plans to do a risk stratification to say, you know, based off of data that we have available, is a member high risk, medium risk, low risk? And our plans do this in a variety of different ways today, and it's not always the same way across the state. So as a part of our Pop Health program, we are developing a standardized statewide risk stratification, segmentation, and tiering process, which will aim to make sure that at least there's a single common standard across the state, so that in one plan, you know, if you're low risk and the same person in another plan would be high risk, instead everyone will have the same risk level, independent of what plan or county they may be assigned to. And they will be developing a specific process for individuals who are pregnant and postpartum based off of those unique risk factors. We also know that intimate partner violence screening is done inconsistently right now, and that can be a major predictor for adverse outcomes and additional services that are needed. And so we will be working to make sure that that is incorporated into all Medi-Cal assessments. We can go to the next slide. We know that often the barrier to improving care is often based off of how and what we are paying providers, and that payment reform and payment redesign needs to be a key part of the birthing care pathway. And so we heard loud and clear from our partners that Medi-Cal's historic reimbursement rates for maternity providers was really lagging other parts of our system. And so many providers just couldn't afford to expand services or participate in the Medi-Cal program. And then we also heard challenges, especially from FQHCs and rural health clinics, for dyadic services, the way that we set up that benefit, which is intended to provide sort of group services to the child and the caregiver, often the postpartum caregiver, that they just couldn't make that work given current FQHC reimbursement rates. So two things we've already done are through the rate increases that went into effect in the Medi-Cal program in 2024, we increased the base reimbursement rates for all maternity providers. And then we also increased supplemental payments through some of our directed payment programs for labor and delivery and hospital-based birthing center services to really level that playing field. And then we also have a directed payment program called the Quality Incentive Pool, which helps reimburse certain types of hospitals for achievements in quality. And we also expanded the maternity measures that are available in that program to reward high quality maternity care. And then in partnership with our federally qualified health centers and rural health centers, we also strengthened implementation of dyadic services by creating a sort of separate payment methodology to really support those practice settings to scale up the dyadic services benefit. And that one is almost done, but still in progress. We can go to the next slide. The other two things that are in progress. So one, we are looking at how we can redesign how Medi-Cal pays for maternity care in general to really create a new birthing care payment model. So that one is still in progress, and you'll hear me talk about later as related to our TIMA project that we've been selected into. And then we will be developing billing and reimbursement guidance for Medi-Cal providers and managed care plans, specifically for licensed midwife, home birth, and freestanding birth center services, as we've heard loud and clear that there's a lot of confusion in that space that needs to be cleared up. We can go to the next slide. So the next bucket is care management and social drivers of health. So as I mentioned earlier, housing insecurity and homelessness, especially for our pregnant and postpartum members, emerged as a major theme. And so really exciting that the transitional rent benefit was approved under the BH Connect 1115 waiver that DHCS got approval for in the last administration. And individuals who are pregnant and up to 12 months postpartum and experiencing or risk of experiencing homelessness will qualify for transitional rent. So we see that as a huge opportunity to really dedicate real important resources to solve this problem. And then we are also going to encourage, and we haven't started this part yet, managed care plans to work with facilities to offer rooming in with short-term post-hospitalization stays for medical respite to members experiencing homelessness and who meet clinical criteria. We can go to the next slide. The other areas where we heard a lot of opportunity was really around, we've had ECM and community supports for a while, but sometimes even those ECM and community supports providers are lacking the specific expertise needed to serve pregnant and postpartum individuals. We know that sort of housing trio for general population is a little bit different than what housing services are needed for someone who's maybe pregnant or has a newborn. And then we also know that there isn't a lot of awareness among members about ECM and community supports benefits. So we are working on, and this is, just started in a few pieces that we will be starting in the upcoming months, thinking about how we can really outreach to key social service organizations, WIC, home visiting programs, CBOs, and others who have perinatal and postpartum expertise to join the ECM and community supports programs so that we can have specialized providers who can really support this population. We also are going to be working with our managed care plans to build stronger partnerships with community-based organizations that are addressing intimate partner violence, because this is another key need for those members who are experiencing IPV. And then also thinking about how our MCPs will partner with housing providers that can really meet the needs of perinatal populations, all the way through 12 months postpartum. We can go to the next slide. The other pieces that we heard about was really, just that providers themselves need some technical assistance and support for scaling the ECM birth equity population of focus, as well as figuring out which community supports can really support pregnant and postpartum members. So we are working on how can we expand ECM referral pathways and really target those areas where pregnant and postpartum members are getting care and increase community referrals to the right types of providers, and then also leveraging PATH, which we have done the last few cycles to specifically scale and support the ECM birth equity population of focus through its cited awards. We can go to the next slide. We're almost to the end of this, and we will open it up for questions for the existing policy initiatives, I promise. I think as everyone is tracking, our Justice Involved initiative is a huge part of CalAIM being able to provide in-reach services up to 90 days pre-release, and then connecting individuals with a warm handoff to all of the services they need post-release. We know, similar to the housing conversation we were just having, that the needs of a pregnant or postpartum individual who's in custody can often be very unique and different. And so in the pre-release Medi-Cal services design, there's a whole section that is very unique and specific to the needs of pregnant and postpartum individuals. And all of that policy has been updated and is available in the JI policy guide. And then we are making sure that there is sort of that they are able to receive these pre-release services. This part is in progress because the calendar of how each facility or county is going live for pre-release services is happening in a phased approach across the state. And then we're also working on making sure that the handoff to the ECM provider post-release is really appropriate to the unique and specific needs of pregnant and postpartum JI individuals. We can go to the next slide. So it's hard to talk about inequality and equity improvement without talking about data. And so we heard loud and clear that lots of people are trying to support pregnant and postpartum individuals in our state. And I'm grateful to live in a state where we have so many programs and so many organizations and individuals really striving to do the best by their clients and their patients and their members. And yet in current state, for the most part, we all do this work in deep silos and often have no idea that my organization next door is also serving the same client or member that I have. And that if we can really get to more transparency and data sharing, we could coordinate efforts better, really reduce that navigation fatigue that we heard loud and clear from our members, and also make our resources go much further, because we know that we are not reaching every single individual who has need of services in the state. And so we're currently in the progress. Medi-Cal Connect is our population health management analytics platform that DHCS is launching to really, to the best of our ability, integrate healthcare and social data, and then have key partners, including plans and providers and state and agencies, use that information for better, more coordinated care across all of our different programs. And then we have some very exciting pilots happening locally that are really looking at how we can do better, more targeted outreach for Medi-Cal members who may be eligible for key supports like CalFresh and WIC and yet are not enrolled. We can go to the next slide. The other pieces that we are working on are really, we have a lot of deep data silos even between DHCS, which has a lot of the healthcare data, and our public health partners who obviously are tracking maternal morbidity and mortality and maternal quality across the state. And so exploring opportunities about how we can leverage each other's data to actually integrate and have better insights and better meet the needs of both providers and members. And then also working on what new measures do we need to track the quality and equity of care for the birthing care pathway. I think many people are tracking in current state. Our measures are really, we track C-sections, we track prenatal and postpartum visits. All that tells you is that someone showed up for a visit. It does not tell you, was it high quality care? Did we avert some of that preventable morbidity and mortality? Are we controlling cardiovascular disease in pregnant or postpartum individuals? So there's a lot of work to be done here. We can go to the next slide. And then as mentioned at the top, even though DHCS is the face of this call, it really is a multiple state department effort, especially with all of our sister Health and Human Services departments, because so many of our programs span and populations span across departments, and there's a lot that we can do if we really partner together. So one huge opportunity is home visiting. And so we know that not everyone who's eligible for home visiting is necessarily being referred or benefiting from this service. And so really thinking through how can we break down silos between Medi-Cal providers and plans, as well as home visiting agencies locally that are mostly funded through public health and social services, and then move forward to really having that be a more integrated referral process. We've also started conversations with our employment development department colleagues and legal aid at work, because we similarly know that even though we as a state have a paid family leave benefit, and we have state disability insurance programs to really cover when people who are pregnant or postpartum need to go on disability, for the most part, Medi-Cal members use these programs far less frequently than other individuals in the state who are more privileged and have access to the process. And so we really want to break down those silos so that all of our pregnant and postpartum members, can get the paid time off that they need and deserve to really bond with their child and recover. We can go to the next slide. The other silos we're breaking down is there is a HRSA grant that is supporting a statewide maternal health strategic plan where the California Department of Public Health, the Office of the Surgeon General, DHCS, and the California Maternal Quality Care Collaborative are really trying to align all of our maternity efforts so we can all row in the same direction, be aware of what each other is doing, and really build upon each other's work. We also are working on the leveraging the Family First Prevention Services Act to support substance use disorder and mental health treatment services, and then also continuing to support the Office of Surgeon General's Strong Start and Beyond initiative, who has very similar aims to our work. You can go to the next slide. Okay, I talked a lot. We are now going to pause. So please ask all and any questions you have. And I'm really excited because we have representation from all of the different program teams at DHCS who are implementing these various policies. So even if your question is weedy, I can phone a friend to help answer.
Thanks, Paula. So the first question we have for you is, how are managed care plans being held accountable for ensuring community awareness and access to covered perinatal services like doula services?
I'll maybe kick us off, and then Bambi, if you want to chime in as well. So there's short answer is there's a number of different ways. So there are quality measures that we look at for maternity services. And I think as people are tracking, we have started sanctioning our Medi-Cal managed care plans when they do not meet those quality targets, as well as issuing corrective action plans. And we have needed to do that for the last few years. In addition, we're the revised all plan letter, the policy guidance I mentioned, where we're going to pull all of the maternity requirements into one place, I think will make it more clear and transparent. Sometimes it is so dispersed, it's hard to know what is the policy or what do we need to do here. So we really want to make sure that we are being good partners and making sure that what we expect in terms of all of the perinatal services is very clear to our plan partners, and then we will be monitoring and enforcing those as well. And then for newer benefits like doula services, we do have an entire action plan that we've been using on the state side to monitor utilization and access. And Bambi, I'll turn it over to you if you want to add more on that front.
My goodness. Okay, yes, I can press buttons. Thank you, Paula. Yeah, I think that's great. And I think the only thing I would add is that we do work with plans in a lot of different ways and through a lot of different venues. So I think the comment that Paula raised was salient in terms of just ensuring that the policy is clear to the managed care plans, because of course we have wide latitude to work with them, and that can be in ways such as providing technical assistance, or we can impose corrective action plans. Or as previously mentioned, we can also impose sanctions on managed care plans as well. And so just want to make sure that our policy is clear and well understood, and the plans are aware of what their obligations are in adhering to contract and APL requirements set forth by the department.
Thanks, Bambi.
We have a next question here on what is being done or can be done to address challenges in finding and accessing perinatal mental health services.
Thanks, Allison. I'm going to kick us off, and then Erica and Bambi, if you both want to respond, both from the managed care and county behavioral health perspective, that would be great. So, this one's challenging. We can't invent a workforce where there doesn't exist. So I think, as mentioned, you heard some of the strategies of we want to make sure our contract language and our requirements for both Medi-Cal managed care plans who cover the sort of non-specialty mental health or mild to moderate services, as well as our county behavioral health partners who cover the substance use and specialty mental health services are clear, explicit, and we can enforce those and look at sort of network adequacy for these types of providers. But we also know we have a workforce issue in this space. And I do think some of the opportunities through BH Connect and the 1115 waiver that got approved, as well as through behavioral health transformation and BHSA, will help us look at where there are gaps and where do we need to maybe invest dollars in building up that workforce for those services. I will also put out a shout out that you'll hear in the next section of things we're exploring. There is a really exciting HRSA grant that LA County is implementing to implement a warm line. We know that it is hard. It is a nationwide training problem that not all psychiatrists or behavioral health providers are trained specifically in perinatal behavioral health, conditions. And so they are piloting sort of a consultation service where someone who is providing behavioral health services can reach out and get expert advice from someone who really does have that perinatal expertise as a way to support and scale services. So excited about that pilot opportunity, and we'll be looking at ways of, is that a model that we can scale across our state?
Thanks, Paula. The last question we'll do for this section is, are there any plans in the future to include more pregnant and postpartum patients to inform policy and landscape analysis?
The short answer is yes. This has been such an invaluable experience, and we do see Medi-Cal members as our partners as we move through this. You'll hear more when we talk about the Transforming Maternal Health opportunity that DHCS was selected to participate in, and we will be recruiting members for sure to help advise on that initiative.
Great.
Okay, I see the clock is ticking down and we have to get through the rest of it. So let's keep going, and we'll try to reserve as much time for Q&A at the end as possible. So the next phase, I'm going to breeze through so we can really get to questions, but there's sort of 6 focus areas where we heard amazing ideas and gaps and needs, but we don't have sort of the resources, the funding, or the authority to implement these right this second. So we didn't want to squash them. We didn't want to hide them. We see this as sort of a strategic roadmap for the future, for the time when our state has resources or desire to implement these, but we will not be taking them on right at this time. We can go to the next slide. So the first bucket is really on access, and I think some of that last question was getting to this. So how do we really monitor network adequacy standards for maternity providers and make sure that there is access? And can we work with our MCPs to really specifically focus on this and looking at access for culturally and linguistically, appropriate care, specifically for our Black, American Indian, Alaska Native, and Pacific Islander populations that really disproportionately bear the brunt of disparities in maternity care in our state. We can go to the next slide. We also, heard loud and clear that there is probably more we can do to really strengthen intimate partner violence screening and then referral to appropriate services, and that more training and technical support would be helpful here, but would require resources. And then one of the barriers that was uncovered around lactation services is that even though the lactation services themselves are covered, we currently do not recognize international board certified lactation consultants, or IBCLCs, or certified lactation consultants known as CLCs, as a provider type that can bill Medi-Cal. So they are unable to independently provide those services and bill, which means that it becomes another barrier for Medi-Cal members to access those services. You can go to the next slide. And sorry, on that last one, the proposal would be we could add them as an independent provider type, but that obviously comes with a lift and resource needs, as well as a potential cost impact. On the behavioral health front, the first proposal here, I gave it away in our last section, but depending on what the lessons are learned from this initiative in LA County, it could be an opportunity with additional investment to develop a statewide perinatal behavioral health consultation line for maternal providers and therapists without perinatal training to really help get these services into the community, even if the individual who's serving that member doesn't necessarily have all of the specific training. And then there's also a lot of opportunities to improve training of the perinatal workforce on trauma-informed, culturally relevant crisis care, as well as to support CBOs who are serving pregnant and postpartum individuals on sort of, all of the ways in which BHSA funds could help identify some of the gaps in this population. So these are all opportunities that, we got recommendations that this training or this support or these toolkits could be really helpful, but they do require resources to put together. We can go to the next slide. And then this last one is really around, when a newborn is being treated for neonatal opiate withdrawal syndrome and needs to stay in the hospital, are there opportunities to allow the postpartum member to stay with them and room in to really promote bonding? You can go to the next slide. The other big bucket is really around maternal care models and access. So we did talk about CPSP and some of the limited oversight here, as well as sort of the modernization that's needed of CPSP with different duplicate provider enrollment processes, as well as the current payment process, which really rewards volume, but not necessarily quality. So one of the future potential opportunities, could we modernize how CPSP services are provided to create some standardization and strengthen this across both our fee-for-service and Medi-Cal or managed care delivery systems, and update it to really align with current clinic guidelines? You can go to the next slide. The other piece here is, as everyone knows, we did launch our CHW benefit. There's a lot of opportunity that we heard to really create a perinatal specialization so that we could have a workforce of CHWs who really understand the needs of pregnant and postpartum individuals. As mentioned, one of the things we're already doing is using our existing loan repayment program for maternity for physicians who provide maternity services. That program is limited to physicians the way it was authorized and exists, but there's clearly opportunity to also create a loan repayment program for midwives, which there's a huge demand for and limited access across the state. And then also thinking about short-term housing for our high-risk pregnant members who live in remote areas, which is a major barrier for them accessing all of the appropriate prenatal care and postpartum services. And go to the next slide. We also heard about the support that providers need and really thinking about how can we train providers so that they are aware of all of the different services that Medi-Cal covers and figuring out how they can refer their patients for those services. We can go to the next slide. And then around data and quality, as mentioned earlier, there's a lot of opportunity to develop better quality measures and then also develop a patient-reported outcome measure. This really came out of some of our members' experiences around feeling, not heard and not respected. And in current state, outside of some of these qualitative interviews that we do, there isn't a great way for DHCS or providers or plans to really get that information on a regular basis. You can go to the next slide. And then within state agency partnerships, as some of you may be tracking, there is an ACOG levels of care designation. There are other states that require this so that they can monitor and make sure that a member is high risk, delivers at the right level of care facility. This is not currently a requirement in California, but there could be an opportunity to partner with CDPH. And then Office of Surgeon General is doing a lot of work around pregnancy risk, and there may be opportunities to scale and support some of those tools. We can go to the next slide. The other areas we touched upon earlier, but obviously there are a lot of data silos. And so really thinking about how can we improve outreach across all the different benefits that members are eligible for, whether that is paid family leave, SDI, WIC, CalFresh. How can we work with our HK partners to really have a better workforce strategy around perinatal providers, inclusive of perinatal behavioral health providers? And then the other thing that came up is there are some states that cover home visiting through their Medi-Cal program. In current state, our evidence-based home visiting models are covered through our Department of Public Health and Department of Social Services, but are not necessarily a bundled benefit in Medi-Cal. So there's opportunities there as well. We can go to the next slide. And then there was a number of opportunities for some of our key subpopulations, especially those who are, suffering from substance use disorder or have child welfare or involved cases, as well as sort of training for labor and delivery around members who come in with child welfare cases or perinatal SUDs, as there's a lot of sort of stigma and misconception in this space that can be really resolved. You can go to the next slide. Okay, so I know that was a whirlwind because we do want to get to TEMA and our closing remarks, but as mentioned, those are ones that are really just proposed out there and not committed to and not sort of moving forward at this time. We will continue to engage with our partners. And so as you attend this webinar and digest the report, if you have feedback on sort of, what's on your wish list from those future activities and which are more important and higher impact, we always welcome that feedback, and you can email it to us and we'll drop the email in the chat. Jen, I know we're short on time, so are there any critical questions we need to tackle, or we can move on to the next section?
That was actually the question we were going to ask, and you already addressed it, so I think we can keep going.
Okay, fantastic. You can keep going. One more. So hopefully what you have walked away with is the report is not the end of our journey. The report is actually the start of our journey. Like, this is where all the work gets going, and it is not going to happen without partnership from all of you. So thank you so much for joining us. Don't leave because we still have a few other things to get through, but you will be hearing a lot more from the department through numerous venues as these various policy pieces roll out. And we really hope that you will take the time to engage and provide feedback so we can make this initiative as high impact as possible. You can go to the next slide. I'm now really pleased to turn it over to Dr. Karen Mark, our medical director, who is going to provide an update on the Transforming Maternal Health model.
Thank you so much. And if you can go to the next slide. So we are really thrilled to let everyone know that in January of this year, the CMS announced that California is one of 15 states selected to implement the Transforming Maternal Health, or TEMA model. And we know that, there's a lot of uncertainty about everything going on at the federal level these days, but we have been meeting with our project officer every week. And as far as we know, this is moving forward as planned. So TEMA is a 10-year delivery and payment model that's designed to test whether evidence-informed interventions sustained by a value-based payment model can improve maternal outcomes and reduce expenditures. And we will implement TEMA in 5 Central Valley counties, specifically Fresno, Kern, Kings, Madera, and Tulare. And we chose these counties because they have a number of challenges. They're relatively rural and relatively under-resourced in terms of providers. And for many of these reasons, there are also some poor maternal health outcomes in those counties. So we're really thrilled to be able to support these counties in improving maternal health outcomes. We will receive $17 million in federal funding over the 10 years, as well as targeted technical assistance to improve, to achieve these goals of improving maternal health outcomes. Next slide. So we will certainly not be doing this work alone. We will be working with many partners to do this work. And we've already begun engaging with many of these partners and will continue to do so over the course of the TEMA award. So this includes provider partners, so OBGYNs, family docs, midwives, maternal fetal medicine specialists, nurses, doulas, lactation consultant, perinatal CHWs. We realize all of these partners are really critical to the work. And there is a large focus in TEMA on really making sure that we are including and utilizing all the maternity care providers that are available, including licensed midwives, certified nurse midwives, and birth centers. So we'll be providing a lot of support in those areas. We'll also be working with various partner care delivery locations, including hospitals, clinics, tribal clinics, FQHCs, safety net practices, birth centers, and other sites of care. And then we have been engaging with and will continue to engage with a lot of partner organizations. So of course, our managed care plans, all the managed care plans in the 5-county region have agreed to participate. So many thanks to them. We couldn't have done it without them. As well as our public health partners from CDPH and our local public health departments in those areas. We know there's a lot of great resources and supports for pregnant and postpartum women in the local public health departments, the California Maternity Care Collaborative, universities, community-based organizations, and other non-clinical partners. Next slide. So this is, as I mentioned, a 10-year effort. It's really divided into 2 periods. First, there's a pre-implementation period, which is model years 1 through 3. So this began in January and goes through December of 2027. And during these first 3 years, we'll be receiving technical assistance to develop the TEMA model. And then we'll be also working to achieve a set number of pre-implementation milestones. And specifically in model year 3, we will be providing through our managed care plans, infrastructure payments directly to providers in those 5 counties to prepare them for implementing value-based payment model. And then model years 4 through 10 will focus on implementing the model. In model year 4, there'll be quality incentive payments that are made available to providers. And then in the subsequent model years, we'll fully transition to a value-based payment model. So next slide. All right, so thanks so much. And happy to take any questions, or I'll defer to you, Paula, if we're going to move on. Oh, you're on mute.
Almost made it through an entire webinar without forgetting to unmute myself. Events team, any burning questions that we should tackle before we move to closing?
I think we have time for one question before we move to close. We've been getting questions about how DHCS will hold itself accountable to implementing the policies that have been reviewed today. How will that progress be reported and shared?
Great question. And while Karen was presenting, I did skim through the questions. I recognize that we don't have time today to answer everyone's questions. We intend to provide regular updates. And so if you haven't already, I really encourage you to subscribe to DHCS's stakeholder blast that we do on a weekly basis and or attend our stakeholder advisory committee meetings where we'll be reporting regular updates. And then we also have our Birthing Care Pathway webpage. So if you want to just get the Birthing Care Pathway updates, we'll be updating that very regularly so that you can see what new materials we've developed, what policy is going out. And then that is our dedicated inbox where as you are working on things or if you have questions or feedback, please feel free to email us because as we said, it's going to take a village to really implement this to fidelity. Any other questions, Alice?
Well, I think we're gonna move to closing to ensure we have enough time and get folks out on time.
Great. Well, thank you all. And as you heard at the start, Tyler Sadwith, who is our state Medicaid director, kicked us off. And I think it's a testament to sort of how critical this initiative is as a key part of DHCS's strategy. And I'm honored that Director Michelle Voss, who's the director of DHCS, is joining us to close this out. So Michelle, I will turn it over to you.
Great. Thanks, Paula. And just want to say a sincere thank you for your time today. As Paula mentioned, Michelle Voss, the director of the Department of Healthcare Services. And it's really great to see that so many people are engaged in this work and care so deeply about the birthing and care experience in Medi-Cal. And want to really thank you for your feedback on how we continue to improve this work. We couldn't have gotten here without you and really your help, your feedback, kind of the frank discussions that we've had with so many of our Medi-Cal members and new parents, in the past and in the years and months to come is so invaluable to us. I also want to thank the DHCS team and Paula for leading this work. This is really has been a kind of a cross-departmental effort and really just want to express gratitude to the team. We will continue to deepen the birthing care pathway over the next several years, and there will be many additional opportunities for community members to provide input. So we will keep you posted on the different ways to engage. And Paula just mentioned the DHCS stakeholder news that comes out every week as well. We will continue to keep you updated on our progress, as we just mentioned, and as we begin implementation of the TMAW innovation model in the Central Valley. And again, your partnership and feedback and insights will be critical to the success of all of this work. So thank you again to everyone. And really hope you have a great rest of your day. Take care. Bye-bye.